All right, empowering the patient. The final step in the pathway of providing patient-centered care, as I was talking to. So now that I have converted you all into budding patient-centered care enthusiasts, I guess it's probably time for me to give you that warning label that's on the outside of the package. If you've decided to go in your practice to adopt all of the principles of patient-centered care, then I need to warn you that you're going to end up with a group of patients who are extremely interested in taking care of their own diabetes. And you say, well, why are you warning us about that? I go, well, that's all fine and dandy that you've created this person who's very interested in taking care of their diabetes, but you've just spent a whole lot of time going through all these different stages, giving them all this information and knowledge. You've just spent all this time painfully going through all the different options for their medical management and allowing them to decide what they would like to do. And you've come up with a superb, or they've come up with a superb management regime, and they've got an absolutely excellent HbA1c, but we've got a problem. We've got a disease that is a changing disease. Diabetes is progressive. It is not static. So while this person might very well be well controlled at the moment, they're not going to continue to be if we keep them on the status quo. The second problem we've got, of course, is that the patient themselves is not a static being. They've got different life expectations as they go through life, aspirations, dreams. They've got life's stresses. They've got priorities that may shift around. All of these things that we know interfere or might stop the person from being able to continue with their patient-centered or their self-management of their diabetes. And so there is one final incredibly important step that we need to do with patient-centered care, and that is empower the patient so that we can keep them on the straight and narrow, essentially. So we need to provide them with the tools to monitor their progression. We need to provide them with tools so that they can adjust their regime. We've talked about this before. We need to provide them with tools so that perhaps that they can recognize when their own self-management abilities have fallen off the wayside, so that they know when to contact the office and come in for some help. Empowering the patient is not difficult. It's just something that needs to be done. The most important, the most powerful way that you can empower a patient is, of course, providing them with knowledge. And I've sort of gone through this ad nauseum, actually, providing you with different ways that you can provide knowledge. The important point that I want to make here is that the knowledge is not only accurate and complete, but that the knowledge is ongoing, that you continue to impart knowledge. And that means that the primary focus of every diabetes follow-up appointment is not about checking that box to see if their HbA1c is still at a good place, not checking that box to make sure that their blood pressure is well controlled and making sure that they've got all the right scripts when they walk out the door. Yes, that's part of the appointment, but it's not the primary focus. The primary focus is to upskill their knowledge level. Mr. Smith, HbA1c 7%, fantastic. That's really terrific. You must be feeling good about that. I see your blood pressure is good as well. Here are your scripts. I guess we'll see you in about 3 months. That is not a patient-centered care visit. A patient-centered care visit goes more like, Mr. Smith, HbA1c 7%, you must be stoked. Fantastic. Do you have any questions? Do you have any concerns? You know, one of the things that we haven't talked about yet is the risk of hypoglycemic episodes when you're tightly controlled, and the risk of having hypoglycemic unawareness. You know what? Let's take a look at your blood sugars, and let's talk about that, because I think it's something that you need to know about. You must grab every moment, every contact that you have with the patient and use it as a teachable moment, whether it's a phone call, your visit, an email. It's about escalating their knowledge base so that you're continuing to hone their skills in self-managing themselves. Of course, bad information is also very influential. And so when you've got that person coming in who's not doing so well, it's incredibly important that you go back to basics and find out where the hole is, or you find out where the misinformation or the misunderstanding has occurred. You need to go back and re-look at understanding your patient. Perhaps there's some change in some of their myths or misunderstandings that you could straighten out. Maria was a little 16-year-old I was managing for type 1 diabetes. She was doing relatively okay. She was very good at manipulating her insulin doses. She knew how to do it. But she came into an appointment relatively recently, and her HbA1c had climbed up into the heavens. It was absolutely awful. Maria, what's going on? I don't know, shrugged her shoulders in a typical teenage way. I don't know. I guess I just seem to forget to check my blood sugars all the time. Really? Well, that's a little unusual because you were getting so good at correcting your blood sugar if it was high. Yeah, I know. We had a little bit more conversation, and it turned out that actually she was incredibly fed up with her mother, who kept bugging her all the time to check her blood sugars because she didn't want to. I said, oh, so you're forgetting to check your blood sugars, but actually your mum is reminding you, but you're still not checking your blood sugars. Right, well, why is that? I guess I just don't want to know what the number is, she said. You don't want to know what the number is, but I thought that you were feeling really confident about correcting the number if you needed to. At which point she burst into tears. And it turned out after a little bit of digging that what had happened was her mother had been saying to her, you know, if you have really high sugars, you're going to die. And what she said to me was, I don't want to know when I'm going to die. So I don't want to check my blood sugars. Obviously, I needed to rearrange her knowledge and her understanding a little bit. Make sure, because knowledge is very powerful. Just telling her to check her blood sugar isn't going to work. You actually need to rearrange her knowledge and her understanding so that she can go back to doing what she really should be doing in order so that she won't die. Another important step towards empowering the patient is to make sure that you put, oops, that's me correcting the information. Another important step is to put in the right supports, not only for your patient, but also for yourself. You know, I've been telling you that if you're going to adopt patient-centered care practice, you need to put the patient, or you need to acknowledge that the patient is expert, put them in the expert role. Simply by acknowledging that does not mean that the person's going to feel particularly expert. It also doesn't mean that you're going to feel particularly confident that they're going to be expert about what they're going to do. This is going to be particularly true at the very beginning of your interaction with the person, and it's certainly also true anytime you're introducing a new skill. So you need to put the right supports in place, mostly so that nobody gets hurt. But also, if you put the right supports in place, you're going to end up with a patient who's going to become confident in their ability to self-manage. And you're also, as a provider, going to feel very safe and confident that the patient is going to be able to do it. I can't think of a better analogy for this than that kid who's learning to ride their bicycle. You know, I think it would be a very rare parent that would throw the bike at the child and say, here kid, go and teach yourself how to ride a bike. They're much more likely to go out with their child, hold that bike, support it, give them tips on how to steer, how to push the pedals, safety tips. At the beginning they're going to give lots of support, but as the child's confidence level and skill level improves, they're going to back off slowly so that the person can then go off on their own. I think the analogy is pretty obvious, and I'm not going to belabor the point other than to tell you what are the supports that we put in place in our office so that a person can feel well cushioned and supported as they go off and becoming independent in their management. There are lots of different ways, and I'm only going to give you a few of them, and I'm sure that you can come up with your own ways of doing it in your office. Frequent visits. Perhaps you've got a nervous parent with a kid who's a new diagnosis of type 1 diabetes. You can easily have them pop in every single day just for 5 minutes. How's it going? How are you feeling? Do you have any questions? Frequent visits is a lovely way to kind of allay their fears, excuse me, and make sure that they feel comfortable and supported. Another way that we do a lot is invite family members. I don't care how many people come in that room. The more people that you've got in the room and hearing the information, the more support they're going to have at home. If you're teaching them how to carbohydrate count, how to manipulate their insulin doses, if you've got somebody else listening to the instructions, when they go home, they're going to have 2 or 3 of them working their brains around what they're doing. We also provide, as I've mentioned before, a 24-hour call service. You have no idea how many times patients have said to me, you know, I've never had to call you, But you need to know that just by having you at the end of the phone, it meant I could experiment. It meant I could try things out because I knew I could get help if I needed it. And it's true, I hardly ever get called. Okay? The other thing that we like to do and that I like to make sure that I say to patients is I give them permission. I say, you have permission to call any time to make an appointment. Now that sounds kind of strange, doesn't it? Shouldn't people feel free to do that? How often do you hear patients have a go, oh, Doc, I'm so embarrassed to be here again. I'm always on your doorstep. I feel like I'm imposing on you. They feel nervous about it. You need to make sure that your doors are open, that they feel welcome. Make sure your front desk staff make sure that they feel welcome when they come in. So there are lots of different ways that have nothing really necessarily directly to do with diabetes where you can make a person feel supported. Just before I completely disappear from this biking analogy, I just want to point out one other thing. If this child were to fall from their bike and graze their knees, I think it would be extremely unlikely that the parent is going to chastise them and tell them to get it together. The parent is much more likely to run forward, brush off their knees, help them back up on the bike, escalate their support level a little bit until the child's regained their confidence and then back off again. That is what patient-centered care is about. It's about supporting your patient in that way. One of the other things that one needs to do if you're going to create an empowered, self-managing patient is you need to put safety nets in place. That's what I call them. Totally my term. You know, one of the biggest barriers that I have noticed in patients becoming their own self-managers is actually us, the provider. How many referral letters have I received that says, don't think the patient's going to be capable of learning that flexible regime that you like to teach. However, I would like you to start them on insulin. Who are they to decide what the patient is capable of doing? Or I might get something from other providers going, you're not going to teach them how to do that, are you? Don't you think they're going to get themselves into trouble? They're going to end up botting themselves out because, you know, they're a bit slow. They're not going to be able to calculate insulin doses. I don't think that we should ever be making assumptions about what our patients can or cannot be doing. If they can push buttons on a cell phone, if they can work their VCR at home and their microwave and all those other complex things that, quite honestly, I even have difficult mastering, then they're going to have absolutely no problem whatsoever mastering any of the skills that you need in order to be a self-manager with your diabetes. Again, I can go back to this bike analogy, actually. I can't imagine that any of you are going to deny a child who has somewhat of an intellectual disability, who's going to be slow to learn. I don't think any of you are going to deny the child the chance to learn to ride a bike if they have a little bit of cerebral palsy or a gammy leg. What are you going to do to help them learn the skill? You're going to put more supports in place. You're going to put some safety networks in place. Perhaps you'll put trainer wheels on. Perhaps you're going to put a helmet on them so that you can help them to be less likely to hurt themselves. We can do exactly the same when we do diabetes management, when we've got that patient that we're a little uncertain about or a patient who's showing a little less confidence. We can put more supports in place. We can leave them in place for longer. We can put cushions in place. If I've got somebody who's learning how to carbohydrate count, but I'm not that confident about how good they are with their math, perhaps I'll just drop their Lantus dose a little bit, raise their blood sugars, and give me that little bit of a leeway, give me that extra room for them to screw up and not get into trouble, but allow them a chance to learn the skill. The other thing that I often do, in fact always do, is provide them with call parameters. If I am starting them out on something where they're going home and trying things out, I come up with a reason as to why they must call me. You must call me if your blood sugar goes less than 60. I would like you to call me if you have a blood sugar less than 70 twice in one day. I actually belabor this point and I say to them, actually, you have just trusted me to make calculations so that you're manipulating your insulin doses and going home. You have trusted me to do this. I now need to trust that you are going to call me when you get these values because I need to know that you are safe. Are you okay with that? Will you promise to do it? People invariably make that promise. I have contracted with them. It means that I know that my patients are safe. It also means that I can sleep well at night, because if I don't get a call, I know they're safe. I don't then have to lie there and worry that perhaps they're not. So put your safety nets in place. So in order to empower a person for patient-centered care, you need to put in a good knowledge base, you need to put in your supports, you need to put in your safety nets, and once you have done all of those things, of course you can then go ahead and start giving them all of the tools. We have talked about these before. You can teach them how to read their blood sugars, remind them about how preprandial blood sugars and postprandial blood sugars reflect different aspects of their anatomy. Perhaps they're not doing so well with their after-meal blood sugars. They can then make a decision about whether they would like to focus on what they're putting in their mouth, or perhaps they'd like to make an appointment to come in and talk about other options because things aren't going well. Give them the information. Perhaps you're giving them some kind of reasons as to what to recognize for when they're out of control. If they're on oral hypoglycemics, give them instructions about when they should be making an appointment to come and see you. If you have on 3 or more days blood sugars greater than 100, please call this number and make an appointment. In other words, give them permission to come on in. If they're on insulin, it would be a different set of instructions that you might give them, and you've seen this before, and it's about teaching them how to do their own insulin management for managing their diabetes. Perhaps you'd like to teach a person how to do a correction factor. They've enjoyed an absolutely delicious meal at a party. Now you'd like to teach them how to do a correction factor. I don't actually usually hand out a handout like this that I've been showing you in the past. I like people to be able to figure it out in their head so that it's very easy for them to do. Sometimes I will give them other kind of assists, such as, let's say we've told them that for every 1 unit of insulin they take, it's going to drop their blood sugar by 20, and I'd like them to aim for 100. Let's just say they check their blood sugar and it's 200. Well, you can go 100, 120, 140, 160, 180, 200. You need to take 5 units of insulin. It's as simple as that. Some people need to have the support. I will write it out for them, suggest they put it on their refrigerator door. They can double check their calculations. For some people, I need to have a safety net and know that they're going to be safe, and this would be my safety net. Okay? But I don't necessarily provide them every time I'm teaching them correction factors. Providing them information about how much their smoking costs is a very powerful tool to give a person. How much does it cost for a month of health insurance? I don't know, but I imagine they possibly could get something. And this is the cheapest box of cigarettes that you have here in the United States. Okay? So giving them little handouts like this is very helpful. We've gone through how you can empower them around their foods, how you can show them that mixing their foods does different things with their post-meal sugars. You can teach them how to read food labels, what they can do for losing weight by minimizing their carbohydrate content in their foods or in their meals, how they can also do carbohydrate counting. There are also, I could go on and on. I could stand here for half an hour and give you the different tools that you might want to teach your patients. For some of you, it might feel kind of overwhelming. How am I going to know how to do all of that? How are we going to do all of that in our office? And I hope that from the previous talks that what you've realized actually that none of these are actually particularly difficult to give a person. The difficult part is remembering to give them to the person. Because after all, it's only when you have created a truly skilled, talented person that you're going to be able to send them off so that they can be independent in their own management of their diabetes. Please do take the time to give your patients the skills to empower them. Thanks very much.